For 25 years, Care Oregon has helped hundreds of thousands of Oregonians get health care. Not strangers, but friends, neighbors, and people you know. When more people have access to health and opportunity, our communities grow stronger for everyone, including you. That's the Care Oregon effect.
Welcome to State of Reform's virtual leadership series with some of healthcare's most thoughtful leaders. And now, the host of State of Reform, DJ Wilson.
All right, well, welcome everybody. I appreciate you joining us here for this virtual conversation, part of our leadership series here at State of Reform. My name is DJ Wilson, one of the folks here working to try to cover some of the politics and policy and of course the sector here in Oregon, and appreciate you making time to be with us. We've got just shy of 100 people here registered today, and of course that I see you coming into the room here, folks like Sam Metz and Maribeth Guarino and Craig Mosbeck and Brian Newbert and all kinds of folks. So appreciate you guys making it with us. So without further ado, I want to first actually thank our sponsor, Care Oregon. They have been just such a great partner. I will say when the COVID economy hit and it was not clear how everything was going to go, it wasn't clear that we were going to be around, certainly here today, 14 months after the lockdowns. It's because of folks and organizations like Care Oregon that helped put wind in our sails and continue to support us, and so we appreciate having them as a sponsor. I want to jump right into this conversation reviewing the legislative session so far in Oregon. First of all, we have Tom Holt, who is principal at the Holt Company, formerly representing formerly at Regents and with pharmacists over the years, and just a longtime hand in Salem. Courtney Dresser, who is the Director of Government Relations at the Oregon Medical Association, and the inimitable Jeremiah Rigsby, who is Chief of Staff at Care Oregon. Appreciate all you guys being with us. Tom, let me start with you. Give us a sense of where we are in this session so far, what you think the story of the session is so far, as we're still relatively kind of at the midpoint of the session here so far. What do you think?
Well, a little more than halfway through the session, I think what's striking is that the remote session and all the disruptions of that, and the kind of lack of pre-session work that because of all of us being restricted from having regular meetings, there's still a lot of big policy moving through this session. It's almost like a regular session in terms of some of the scope and depth of some of the issues being addressed. And just outside of healthcare, there's a big police reform effort. Now that one did have a lot of pre-session work. In the last week or so, we've had headline issue around gun controls. That's another really big issue, and some other big initiatives like that. And the legislature deciding what to do with various tranches of federal money coming down. So that to me is the big takeaway, that unlike some other places where legislators before the session said, hey, save your big stuff for next time. We're just going to focus on COVID response and keeping our budget balanced when we don't know what the numbers are. I think the other big story is that budget really is not the crisis issue that it looked like it could be a year ago. We're almost back to a normal trend line from a state revenue perspective, even though there's this terrible human story of people in the lower end of the income scale who were affected by shutdowns, restaurant workers and hotel workers and so on. And there's been a policy response to that federally and from the state. So it's sort of weird to be in this bad time, but situation normal, progressing like a normal session and without a lot of kind of big picture disruption on policy. A few of the big things that I see is that it's a good session to be a provider. There's been a lot of action around just provider update kinds of things. The physician assistants have a rewrite of their statute to simplify the back office physician assistant administration. Pharmacists are getting more prescriptive authority with a bill to allow them to prescribe HIV therapies. And the naturopaths have a parity bill that's now in Ways and Means, but that's a door they've been pounding on for a long time. So a good session to be a provider, not a great session to be big pharma. There's a price control bill, there's a pharmaceutical reps licensing bill, and so on. But then things that I think we see it as far as kind of major health things moving, cover all people, 100% general fund Medicaid expansion for adult undocumented immigrants. Ways and Means will have to decide how far up in age that is, if it really is all or not. But as long as money remains flush, I think that gets funded. We have a big telehealth rewrite that Courtney and I have been very involved in, and that's a big deal. So lots of big stuff going on.
Well, let me ask you, Courtney. Tom says this is a great session to be a provider. How is the session going for the Medical Association?
We have our pros and cons, right? Our ups and downs, like in every session. I think, we came into this session hoping for, with so much, time spent on COVID, and the response to COVID and the response and making sure our providers are well and able to take care of their patients and themselves. We had hoped the session would be limited in some ways, but as Tom says, there's some really good things happening this legislative session for the provider community. Telemedicine, we have seen what telemedicine can do. The COVID pandemic is like a pilot project for telemedicine. And we know that the payment parity piece is really vital for our providers, not just during a pandemic, but post-pandemic, during wildfires, during an ice storm. Being able to take care of your patient from the safety of your home, if that's where you are during a lockdown, is really important. So we're very excited about that bill and very excited to see that move, and really excited to see the bipartisan support of the telemedicine bill.
I want to remind folks, of course, here in this little box on the right of your screen, you can see that there's a Q&A section, and of course you can post your comments, your questions. You can then upvote those by clicking on the little thumbs up icon so I can see the priority questions, and we'll make sure we get those integrated in. This should be a very interactive conversation, and we hope it will be. So, Jeremiah, how about from the view of CCOs, from the perspective of the payer in many instances, how is this session treating you guys? I think maybe it's been a little less fabulous than, maybe not fabulous, but you tell me, how has this treated you guys?
I mean, I love calling managed Medicaid policy development fabulous and try to define what that means. I think, it's I agree with what Tom and Courtney said. It's especially, Tom's comments around where the budget conversation usually is and kind of where it's at here. I think I would also acknowledge a sentiment right now that this is a for real time of innovation in a way that feels a little bit different than it has in the past, really 6 years. I think at the end of the Obama administration, there was so much effort to protect the ACA. And then you went into the Trump administration and those early attempts to repeal the ACA. And so it feels like for the last kind of 5 years, really 6 years, there's been this kind of dark cloud over, like, let's just protect what we have. And in conversations right now, in the way it feels as though we are talking about healthcare transformation in Oregon, I think there's a renewed energy, and you've got big pieces and stimulus packages that bolster the ACA, whether that's, subsidizing folks on the exchange up to 150% of the federal poverty level, or different things that people are trying to do to expand coverage. It almost feels like there's an air of innovation out there again, and that from the CCO perspective has felt a bit different. I think with CCO 2.0, we really worked hard to get the legislature to kind of get on the same page and agree about what we might want to accomplish, and then went off with OHA and OHPB, and that was a year-long process, and that was pretty innovative, but that wasn't as much in the legislature. This year, as Tom mentioned, we have cover all people, and that's, I think, a huge step of extending the coordinated care model to as many people as possible, to really trying to cover Oregonians regardless of their immigration status. We support, I think, both efforts, both 2164 that's in rules right now and 3352, which are pretty similar. It's just talking about really the potential size of the project, the size of this effort. I think in this legislative session too, I mean, this focus on equity has been real, and we've heard it from the agency, from the governor, from the legislature. And I think for CCOs, equity is an incredibly important issue, but I think I've said something like this before. A lot of equity efforts feel like just saying equity 3 times and being like, we did it. We're talking about equity because we've said the word equity. Legislating equity within the healthcare space is very hard, right? How do you legislate the right things to undo decades, centuries of systemic racism in a healthcare system that was built by white folks, kind of for white folks? And I think everybody in the healthcare section recognizing the lasting damage. One of the big pieces, other than cover all people, I think that we've been proud to support is around the Data Justice Act. I think as CCOs, we've had a front row seat to this population, and we've talked at a high level academically about how to address disparities within populations that have been historically marginalized. We also know that we don't really know the race and ethnicity real-D data of about 40% of our population right now. So it's one thing to talk about equity and talk about addressing disparities, and it's another thing to actually put things together to do that work. The Data Justice Act, I think, is a really, really good step towards talking about a collaborative way to collect this information on the people that we are serving. I think one of the things we always want to watch out for is when we're doing anything in innovation, when we're doing anything that feels like healthcare transformation, it really is a partnership between what we're trying to accomplish as a state and the public policy development and regulatory system, but also the plans and providers, and making sure everyone feels comfortable with what we need to report, what that administrative burden is going to feel like. But I think with the Data Justice Act and where we're at right now, and this, again, recognized need to really make strides in that space, everyone's coming to the table saying, we're going to take on this administrative burden.
Your audio is breaking up on us here, Jeremiah.
I'm sorry. I got a phone call coming in. Can you hear me now?
It's cutting in and out, but I'm sure it'll reset here in just one second. Courtney, let me ask you to follow up on some of that. I think Jeremiah's point is a very good one, that a system that was built for white people or by white people for white people is going to have some structural challenges to address diversity, and that is just hard to do. It's hard to do from a legislative perspective. How do you think the events of the last 12 months, 14 months have changed the conversation around diversity in policymaking in Salem this year?
I agree with Jeremiah. We can say the word equity 100 times and it doesn't necessarily, how do you legislate all of that? And there's so much good work happening in Salem, and the Data Justice Act is just one of them. There's also great work on healthcare interpreters, ensuring everyone has proper healthcare interpreters. Now, how do you take that and put it into the frontline office, into your primary care setting, into training your staff to ask these questions in a meaningful way without causing more trauma to anyone, either the patient or the staff. We've heard stories during Real D and COVID that concern us, and we need to ensure that not only is the data appropriate, it's good data, but that doesn't help us if we're missing it. We want people to feel comfortable asking those questions and comfortable answering those questions and feeling heard. And that's going to take some best practices and training from our provider community. And I think that's the piece where Jeremiah was talking about kind of working together and getting everybody comfortable in that space. That does not happen overnight. I'm proud of my association, the Oregon Medical Association, prior to COVID had really stepped up to really look at equity in the workforce. And we've been doing that work. And so when after the incident in Minnesota and the death of Mr. Floyd, really then looking at racism and what do we need to do and how can we be active. And so our association has an amazing amount of providers who are sitting around a table and talking to each other and sharing their stories, and then producing some really good principles and policy for OMA to go out and work with our membership in our communities. And I'm excited about that work that we're doing.
So, Tom, let me ask you this question about the bipartisan nature of healthcare today. 10, 12 years ago, I think healthcare was a very bipartisan policy issue. There's been a lot of politics around healthcare and health policy in the last decade. How bipartisan would you say healthcare is today compared to a decade ago?
Oh, great question. I think in a lot of ways it's much more bipartisan when we're really getting into the how do we do things like coordinate care, how do we enable data flow, the real D things that Jeremiah was talking about. There's a lot of really good work it's not sexy, isn't going to make a political headline, but is critical to the success of this, where there's really good bipartisan support to make sure that the resources are going to be there for the health authority to do its end technically. Partisan divides haven't gone away though. There's a bill around mergers and acquisitions and giving the health authority oversight of mergers, acquisitions, and affiliations within the health sector. It's an absolute partisan divide on that. It's a really ambitious policy initiative by the proponents. And so that it's still there, but I think it's not nearly to the degree it was in, say, 29, 10, 12, in there.
Jeremiah, let me ask you about that consolidation bill in terms of M&A activity in the legislature. The purpose, I think, of that, or the interest of some legislators, is to forestall the both consolidation in general, but specifically from outside interests who might, often for-profit entities that have bigger pockets. What are your thoughts on that consolidation, not just the legislation, but the effort to try to address it in the legislature?
Yeah, so it's interesting because I think, first of all, for Medicaid,
your audio is still a grind there, Jeremiah. It's a good thing you guys are friends, because you would think less of me if this is how we were always doing things.
So I think CCOs have been under rules for mergers and acquisitions for the last year. There were temp rules that were similar to what's in the bill, and I think they were made permanent. And so for us, I think we've recognized and seen, and to be candid, I think a lot of this came from some talks about certain health plans joining with certain hospital systems, and the real need for transparency in that, and the real concern of the impact that's going to have on healthcare in Oregon. And I would say at a high level, for the state to be, held accountable as a smart purchaser of healthcare, and the secret sauce for CCOs specifically being the fact that we are supposed to be responsive to the community and that we are supposed to be community-based. I understand why there would be a need for transparency when we're talking about these entities that contract with the government merging or being acquired by bigger entities. I get that. I think where the fight is at currently in the legislature isn't as much with CCOs, because we're under certain rules already when it comes to mergers and acquisitions. So I know there's a big shift towards consolidation. I know there's a lot of questions about what that looks like. There's, I think, a part of the public interest that is well served by transparency. I think there is also a question about how mergers and acquisitions legislation and regulations, what it's going to do to slow down any mergers or acquisitions, or what it's going to do to actually be determinative of what happens if two healthcare entities are interested in merging together. It's not clear to me, but I understand the need for transparency, and we're subject to that right now, and we're okay with that. We're a nonprofit, and we have nothing to hide. Like we would want the community to have input on the things that we are doing. So that's a rambling answer. I apologize. I'm just hoping you actually could hear me though.
Yeah, no, we can hear you now clearly, and I can see you. I want to make sure I see David Russell saying no, can't see. Elise Fritz says no, can't see. Hopefully that is sorting itself out with folks. But Courtney, let me ask you about that same consolidation question. Is that legislation or the principle something that OMA gets behind?
We came at that bill looking at our, especially with our independent clinics and independent providers, looking at how they continue to be independent because they want to stay independent. But the bill has, in its first approach, was so broad. It included just about every single contracting piece that any provider did, even with their panel and insurers for reimbursement. So the amendments and the conversation were very helpful. We're still not at a place where we think this bill is perfect yet. But again, transparency is important, and we understand that. Eliminating benefits that this state has approved, like reproductive health equity, we would not want to see benefits being denied the patients due to a merger. So some of the goals of the bill are pieces that OMA agrees with. The process and how we get there and get to the right bill is always the devil's in the details, right? So we were really at that table looking for our independent providers who want to stay independent, don't want to necessarily consolidate. But we also want to be there for our providers who, at the end of their time in practice and have a healthy practice and want to be able to sell that practice, being able to do that so their patients still have a place to go. So it's, we've got to find a balance there, and that's where I think we are at that table.
Tom Patrick Jones, who asked a question about HB 2508 regarding telehealth. And he asks, how does it ensure equitable access for Black, Indigenous, and people of color and rural Oregonians for particularly mental health, but physical and mental health consolidation? How does that legislation ensure equitable access across demography and geography?
Well, I think that's a really good call out. The fact that audio only is included is really critical, particularly in behavioral health. A lot of people have preferred going to audio only. And so but that's also an issue for, if you're in a place that doesn't have great broadband, which is in Oregon, just about anywhere outside a metro area on the I-5 corridor, you need to have that option. And so I think, we took a lot of care in putting the bill together, and Representative Prusak took a lot of care in looking at the access issues around telehealth to make sure that we were broad strokes inclusive of some of the hardest populations to reach.
Jeremiah, another question speaks to this coverage issue that you mentioned earlier. It says about 6% of Oregonians, this is from Michael Goldberg, about 6% of Oregonians lack any kind of access to health insurance, but it doesn't include the underinsured. What can be done to shore up access for the underinsured as well as the uninsured?
That's a great question. I think my knee-jerk reaction is to talk a little bit about where that option bill is going. I think it's 2010, HB 2010. And I think over the years, my experience in Oregon, we have a lot of work groups and we have a lot of blue ribbon task forces. And we've always approached this issue to talk about access to care. And we've never really approached an issue about access to the right kind of care. What about underinsurance? I think it's probably important to define what underinsurance means. I think that, again, for Care Oregon and our CCOs, Columbia Pacific and Jackson Care Connect, and our work with HealthShare, we're in we're in Medicaid, and we have a benefit package that we think is fantastic, with years of refinement with the Health Evidence Review Commission, and we think that benefit is pretty generous. That feels like the right type of insurance. And getting back to that public option bill, I think the direction to both DCBS and OHA to come with an idea of what a public option might look like, whether that involves a Twitter model. That's something I think is really interesting, because I think it does talk about underinsurance that have the marketplace and the exchange haven't been the most stable things since they've been implemented in Oregon. I know it got off to a rocky start, and that's not really where Care Oregon is. Talking about public option does have impacts, right, on marketplaces that have stabilized. And so what that means, I think, is there's a lot of details to work out, but just the state saying, hey, underinsurance might be an issue, I think is important, because it gets to talking about the quality of benefit packages at different levels of insurance. And I'm biased, but we've got a really great foundation to build on in the Medicaid space.
Jeremiah, I think the Bluetooth connection is just like, I think if you lean back 2 inches, you get rough with us. So you gotta lean into it.
I think to tag on to Jeremiah's comments and maybe a little bit different angle on it, I think we're kind of hung up on the bumper sticker of public option. And the real issue is affordability of appropriate coverage. I remember that before the ACA, the most popular products in the individual market were very high deductibles. $7,500 deductible or $8,000 deductible was the number one product, and a $10,000 was the number two product in the market. Since the ACA, the metal levels have creeped up. And what do people do? They buy what they can afford for a monthly premium, but then something happens and they've got a huge out of pocket that they can't afford. The road to solution really is subsidy in some form. It's not necessarily creating another product, but finding a way to subsidize it so that people have protection that they can afford to buy and aren't going to be put into a crisis financially by a health event. So I think we should be looking at things like, can we enhance the reinsurance program to bring down some of the out-of-pocket models, behind the scenes, just as the federal subsidies do, but not enough for those who are really struggling to afford coverage. I think that's probably a more doable thing, is just to look at some straight subsidies rather than erecting a new product program.
I want to ask Sam Metz's question here of you, Courtney. He asks whether there's any controversy regarding SB 428, which would extend the deadline for the single-payer task force established in SB 770. What do you think about whether there's controversy there or not?
I have not heard any controversy. I think moving forward on studying something is a good idea. I don't think that's changed. What people think about the outcome is a different conversation, but studying an issue and looking at an issue fully and vetting it fully with all the parties is never a controversy in my book.
Do you think that the work around a single payer at the task force level and just the conversation of the last few years, including that which happened in the presidential primary, do you feel like that has moved the needle in some ways? Maybe it's moved the needle about support for single payer, maybe not, or maybe it's moved the needle in terms of some more engaged government purchasing strategy? What do you think, Courtney?
I think that's a good question. I think, we get hung up on all the titles of everything, but looking at what do we want as consumers and providers, and mostly what do we want as consumers. And so I think you're looking, when you see things like low value reports and you see value-based payment, global budgets, there's a lot of kind of alphabet soup here, but what is it we want as a community that's going to get us to quality healthcare with quality providers and at the low cost? And I think 889 group, the value-based group that's being set up with OHLC and OHA, and some of the other work that's happening, including the single payer task force and the universal primary care group that's been formed during the interim, and the work they did with I think House Bill 3108. All of those get us to something, but the something I think is the piece that we're always having trouble getting to, and with so many stakeholders and factors that we have to consider. I think for OMA, that being on the value-based committee is really looking at how do we have really high quality care at good value for our community, and that doesn't always necessarily mean the lowest price, but some things may need to be at a lower price, and some things may not. We need to just determine that as what's important to us, and what our standards are.
Mary Maslow has this comment. She says, to add to the public option conversation, in Washington State, only approximately 1,800 individuals are enrolled in public option plans there, and that they are different than the standard plans. So what do we think about this public option? Tom, do you think it's a distraction from extending the transformation model in Medicaid into things like, teachers and public employees, which was, of course, the original vision 9-10 years ago? Do you think it's a distraction, or do you think it's a natural evolution of not just the federal conversation, but where Oregon's transformation work has been?
I think it's a good term, DJ. I think it is a bit of a distraction. So we get hung up on the name. We get hung up on the idea of, we've got to create a brand new program, when the real issue is getting people into coverage and improving the value of care delivered. And if we can push down the cost, really push down the cost curve, we create headroom to do the subsidy that's going to be needed for those who truly can't afford coverage. Whether that subsidy looks like expanding Medicaid into something people can buy into at a subsidized rate, or some other method. I guess practically speaking, I think it would be easier to build on what we have and catch the momentum of the important initiatives that are underway than to really try to create an adjacent thing that's going to have to be managed all by itself.
What do you think the 2022 Democratic gubernatorial primary, the impact from that is on this year's legislative session?
We already have to start thinking about that already.
Maybe not. That's why I'm asking.
It feels like we're just got done. I mean, politics and elections are every day now. It's not. I mean, every issue is politicized in some form or fashion, even healthcare. As much as a lot of times when you look at the end of the day, bills pass with a bipartisan support and easy peasy, but it's like, everybody has to kind of have that little edge, elected official wise. So that edge is always there, and that politics is always there. So I think, obviously for the next 2022 and what's going to be happening, I mean, the intersection between COVID, the economy, the social justice, equity, it's just all intersecting all at this unique time during a pandemic. And then we're going to have a governor who's going to have to step in. A new governor is going to step into a lot of this that will still be, it's the recovery process for not just for the pandemic, but the wildfires and other things. And the equity, social justice that's happening. This is a long path of recovery and change and implementation of innovation and that we need to do to make this just make this better and make this not, hopefully COVID and other things not happen again. So how do we do all that? And someone's going to have to step into that role. And so I think everything is politicized. Everything's going to be part of that discussion.
Yeah, everything's political these days. Jeremiah, thanks for adjusting. Looks like we got you back in.
Hopefully you can hear me. Oh gosh,
yes.
Yeah, I don't know.
Yeah. Well,
So
I
is
appreciate
it
your
still the
agility and
gubernatorial?
dexterity on technology.
Is it still the governor question?
Yeah, I'm interested in the politics of 2022 and how that's impacting this at all, particularly with Speaker, with a bunch of folks interested in running. What are your thoughts?
So yeah, I was gonna say, I'd shift it to I think it hasn't really impacted how we think about the work we have to do, and that's because number one, the sentiment that's here right now with the administration, but number two, we're starting our waiver conversation, right? And this idea of innovation is kind of bigger, and this idea of the future of transformation is bigger than I think the agency and the governor and the CCOs and the legislature. It's a huge conversation that involves all of us, and I really do wonder, as we move into a space where we have a different administration, we have a really good opportunity with the waiver renewal, we have money coming in and a desire that feels bipartisan to protect the healthcare of many, how we talk about the many different strings of conversation, whether that's the 889 group or the 770 group or single payer or public option, or what we do with the consumer advisory councils and the Medicaid advisory. I mean, a lot of that seems to need to be coordinated into a pretty coherent narrative. And I wonder if we need to, less about the governor's office, less about the agency, but more about a forum where all of these different stakeholders that are inevitably going to be impacted by this work have a place to participate and help really connect to a coherent storyline for what healthcare transformation means in Oregon. And I've been biased, but I think that's really the Oregon Health Policy Board. I think right now we have a lot of these different groups in managed Medicaid, whether it's with metrics and scoring or around quality, that are in Medicaid Advisory Committee that are already reporting into the Oregon Health Policy Board. We know that the legislature has a very limited amount of time to discuss very complex issues. In CCO 2.0, that became very clear. It's really hard to have a very deliberate and in-depth conversation about healthcare transformation, considering the fact the legislature is only in session for 6 months and each bill gets 20 minutes. I think the House Healthcare Committee went through 150, 160 bills. How are you going to have a coherent conversation on transformation in that amount of time? And where can we as a state really put legwork into working through some of these things, building on the fact that I've known Tom and Courtney as long as I've been doing this, and they've been representing these interests for some time, and we all know each other. We all know these communities, and to me, regardless of what happens politically, where Oregon is special is we've all already been working together to advance healthcare reform. How do we harness that energy moving forward? And I would love for the governor's office and the agency to be a part of that. I think any of the nominees that I've heard rumors about or seen in the paper, we've all talked to about healthcare at some point. We know that they have healthcare chops, and so long answer, but I feel like I just my mic hasn't been working and I've been wanting to talk, so sorry.
It's okay. It's okay. Jeremiah, I'm going to give you the last word here, but first I'm going to go around and ask Tom and Courtney this question. I'll ask each of you. Tom, what gives you hope? What gets you excited about the future of healthcare in Oregon here in 2021?
Well, I think a lot is, what Jeremiah just pointed out, that there's a lot of us who have been working on the policy side together for a long time, and that helps a lot. We also have a core of legislators who are relatively new to the healthcare space, but now they've got a couple of years under their belt, and they're getting to know each other and know us, and see a new-ish CEO team across CCOs, commercial carriers, hospital systems, who have all come into most of whom have come into their roles in the last couple of years. They've had the opportunity to get to know each other. So I think there's, that we've rebuilt or reinvigorated the community of healthcare in the state over the last year or two. And so as we get a new administration, where it's very possible we could have a governor who does not have a lot of background in healthcare, there are going to be people ready to work with that new administration and help bring them, whoever it is, up to speed. I think that's a key challenge for the healthcare community, is that whoever emerges out of what will be a probably pretty closely fought primary for the first time in a long time, to engage whoever the top one or two people's teams are early, so that we don't have some disruption as we're going into the waiver conversations and other key initiatives really coming to a point where there's a next big step to take.
Courtney, what gives you hope or excites you about the future of health policy and healthcare in Oregon in 2021?
Well, I'm going to be a little kind of Pollyannish, but just look at what the provider community, and when I say that, I say all provider types, hospitals, insurance, the entire kind of systems, what they have done in this last year and a half, how they have responded to something we have never seen in our lifetime. How they, we have battled over making sure there's PPE and who has it, all of those things are there. But the fact is that this community had to, in a really an impossible time, come together and solve for a problem that was slapping us in the face, and they did that. And there's so much to learn from what we've done, and there will be a lot of opportunity for us to look back and say we could have done this better. And I think we all have that list. But what this community has done to support each other and to get through that, and the work to get vaccination clinics up and running, the work to get PPE to the right people, the work to train everyone, to get volunteers to get involved. I mean, all the stuff that they have done, and also continue to see patients and continue to help those who don't have COVID. I mean, it's just amazing, that work. And so to me, I'm like, if we can kind of get through that, we can kind of help and figure out the rest of this, right? If we can handle that and work together and do that and solve for that. We still have a long ways to go, obviously, when you look at the numbers and see what's happening. But I think that shows that there's opportunity to really solve any problem in front of us if we can continue to work together in that format.
Jeremiah, the last word on this one. What gives you hope and excites you about healthcare in Oregon in 2021?
Well, I think at a high level, the biggest thing is we have a really good infrastructure, kind of building on what Tom and Courtney were saying and what I was saying before. I think at Care Oregon specifically, at the beginning of CCO, with CCO 1.0, kind of like equity, we would say integration, and just hope that integration would happen, right? We've now been working for the last 7 to 8 years on what behavioral health and oral health integration actually means. And I'm not saying that we've got it perfect, but we have an incredible amount of information and an incredible amount of learnings to really talk about how different it is to integrate behavioral health in Jackson County versus the metro area versus the North Coast, and what we need to build and what we've built for that. I think that, combined with where the healthcare community is, where the legislature is in being supportive of healthcare transformation, being interested in talking about things both controversial and not controversial, all to move healthcare transformation forward. And then having an agency that I think is also picking up and learning on what happened in CCO 1.0, what's going on in CCO 2.0. Just a lot of potential, I think, to build on really 30 years of success in a waiver, last decade really for CCOs. A lot of things we've learned, there. And I think a lot of support for, again, being biased in the Medicaid space, but the coordinated care model and what that means can mean a lot of different things. I really agree with what Tom and Courtney said. Get hung up on titles like public option or single payer. Let's talk about how we get the best quality product to the right people at the right time. And I think we have the things in place to do that, and a solid foundation to build from.
Jeremiah Rigsby, the Chief of Staff at Care Oregon, Tom Holt, Principal at the Holt Company, and Courtney Dresser, the Director of Government Relations at the Oregon Medical Association. Thank you guys for being with us, and thank you all for sticking with us. I see, Sam Metz, like I said, and Eric Hunter, and who else? Ruth Adkins, and Greg or Jeff Knapp, and a bunch of folks, Mary Maslow, Greg Mossback, who all stood with us the whole time. So thanks for doing that. I appreciate it. We will be able to put this together in a clearer form. We record this in a couple of places, so we'll post this at our site. You'll be able to see it in its entirety, even if the video went sideways for a little bit. And I appreciate your support of us here at State Reform and for reading our stuff. Thanks, everyone.
Thanks for joining us in this virtual conversation and for your support of our work at State of Reform.